So we can start.
Okay.
So thank you everyone for joining us for the Asian Cardio-Oncology Society Inaugural Conference Series 3. Without further ado, I will now request our chairperson, that is Dr. Vineet Talwar, Senior Medical Oncologist from New Delhi, to please introduce our keynote speaker and the topic.
Well, it is my great privilege to introduce Professor Susan Dent. She's a co-chair of our Asian Oncology Cardio-Oncology Society, and she's a medical oncologist at the Duke Cancer Institute, and she has a host of other institutions. She's founder and past president of the Canadian Cardiac Oncology Network, that is the CCON. And she's a community member of the International Cardio-Oncology Society. And she's also the Associate Director of the Breast Cancer Clinical Research and Co-Director of the Duke Cardio-Oncology Program. Apart from that, she has authored a book on cardio-oncology, which I was just going through in Amazon, and she would be speaking on the preventive strategies in cardio-oncology. So, Professor Dent, please, over to you.
Thank you. Can you see my screen now? Or should I share?
Not yet.
No, not yet.
We'll share the screen.
I'm going to share it. Here we go. Can you see it now?
Yes, ma'am.
Great. Okay, I'm just going to minimize you guys so I can see my own talk. Okay, everyone can clearly hear me and see my screen?
Yes, ma'am.
Great. So thank you, first of all, for inviting me to speak at this series of talks that you've arranged. I think it's a great opportunity to share some of the experiences that I've had. And today I'm going to be speaking about prevention strategies in cardio-oncology. So over the next 20 minutes, this is what I'd really like to cover, is discuss the rationale for prevention strategies in patients treated with potentially cardiotoxic cancer therapy, to review some of the current evidence supporting prevention strategies, or at least discussing what evidence that we have, and then to talk a little bit about knowledge gaps and research that's being conducted in this area. So let's just look at the scope of the problem. It's interesting, when we think about it, but approximately 30% of patients receiving cancer therapy will have some sort of cardiovascular complication. And as we know, it's not just heart failure. It could be an arrhythmia, it could be a thromboembolic issue, it could be hypertension, and so on. We know historically in anthracycline-treated patients that the incidence of significant cardiotoxicity and heart failure can be as high as 5 to 10%, depending on the dose, the lifetime dose of exposure to anthracycline and the duration of exposure. We also know that left ventricular dysfunction is reported in up to 16% of adult breast cancer survivors. And I really think that is reflective of the amount of anthracyclines we have traditionally used in this patient population. And for breast cancer patients exposed to trastuzumab, we know about 2% will develop symptomatic heart failure, but importantly, up to a third develop asymptomatic left ventricular dysfunction. And how important is that? And we can certainly discuss that later. So why consider prevention strategies in cancer patients? Well, first of all, I just wanted to discuss what do we mean by prevention, because this term is used quite widely when people talk about prevention strategies. Primordial prevention really targets the general population prior to the development of risk factors for cardiovascular disease, i.e. hypertension and diabetes. So that would be your very healthy population with no risk factors, and you're trying to look at how to prevent the development of these conditions. Primary prevention really targets those patients, such as cancer patients, with cardiovascular risk factors who are then going to be exposed to a potentially cardiotoxic therapy. Secondary prevention is those patients who already have symptoms and signs of cardiovascular disease, e.g. structural heart disease, and you're trying to prevent a further event. And then finally, tertiary prevention targets patients with cardiovascular disease where they already have this established, and you're really looking at trying to optimize their quality of life while delaying premature mortality. And here's just sort of a picture view of that. You can see here sort of where you go from primordial prevention, the healthy person, through to someone with a cancer diagnosis, and then you're exposing them to potentially cardiotoxic therapy. And then later on, when they develop, hopefully they don't develop, but they develop structural heart disease and so on, then you're looking at secondary prevention and so on. So we'll be focusing, I think, on this area where those patients are diagnosed with cancer, exposed to potentially cardiotoxic therapy, and they may or may not have risk factors, but we're interested in how we can prevent them from moving on to what would be classified in some cases as stage B heart failure, or at least more structural heart disease. So what is the rationale? I think obviously we want to prevent cardiovascular toxicity in patients that are receiving cancer therapy. As a medical oncologist, however, what I want to do is I want to complete the prescribed cancer therapy. And so I think in instances where oncologists become concerned about, things such as drops in ejection fraction and hold therapy, we do this in a sense are holding potentially curative therapy because we're worried about cardiovascular toxicity. And the example I give here is really, I think, a great one. So when trastuzumab was first approved for treatment of early stage breast cancer, we were doing echocardiograms every 3 to 4 months as recommended by the product monograph in the FDA. However, when oncologists saw drops in the LVEF, they became concerned, particularly if the drop was below 50%, and often would hold or even stop trastuzumab therapy because of this, without seeking the help or opinion of a colleague, a cardiologist. And we now know that asymptomatic drops in LVEF don't preclude necessarily continuing with trastuzumab. And so I think that's just highlights the issues around what oncologists may perceive as significant cardiovascular toxicity from a compound, and what a cardiologist may say, well, we can actually help you with this. We also want to prevent exacerbation of pre-existing cardiovascular disease. And of course, we want to ensure long-term cardiovascular health in our patients into survivorship. So let's take the case of a 55-year-old postmenopausal woman with a recent diagnosis of breast cancer. And she has a T2, so over 2 centimeters, N1, M0 ductal carcinoma, so node positive breast cancer that's estrogen and progesterone receptor negative and HER2 positive. She has a history of hypertension, and now quite commonly we will offer these women neoadjuvant therapy, in this case with TCHP, which is taxotere carboplatin in combination with trastuzumab and pertuzumab for 6 cycles. And then of course plan would be to continue the trastuzumab and pertuzumab out for 1 year. She has a baseline echocardiogram which shows an LVEF of 50% and a global longitudinal strain of -19%. She's referred to cardiology to consider primary prevention strategies. What would you recommend? Well, let's just look at what her history is. She's got some hypertension. We're exposing her to these 2 HER2 targeted therapies. And I would argue that she has a borderline normal baseline LVEF. So when we think of general strategies in terms of prevention of cardiovascular morbidity and mortality, this is sort of a nice, easy approach. And Javed Malehi from Vanderbilt has talked about this approach for a number of cancers, not just breast cancer, but also published in prostate cancer as well. And while this may seem quite intuitive, I still think it's an easy thing to sort of apply to all patients. So A, being awareness of the potential cardiovascular dysfunction of a patient based on their risk factors and based on the therapy that you're proposing, blood pressure control. And I could say now, moving and living in North Carolina, this is a big issue. Many of our patients here come to see me and their blood pressure is not well controlled at all. And then we're going to start them on therapy. Cardiovascular screening as needed, cholesterol control, avoiding cigarettes, cardioprotective medications. What about diabetes control and healthy dietary choices? And again, where I live in this part of the States, diabetes is a huge issue for individuals. And then I'm not going to talk a lot about exercise, but I think this is certainly very important in talking to our patients in terms of cardiovascular health. And then there are the choices about what kind of cardiovascular imaging that you might choose to assess and monitor these patients. So we're going to focus on the cardioprotective medication and some of the literature that has come out in the recent years looking at this as a primary prevention strategy. So I'm going to briefly just mention Dexrazoxane. It is thought to be an iron chelator. It's the only FDA-approved cardioprotective agent for anthracycline-induced cardiotoxicity. It works by changing the topo-2 configuration and preventing essentially anthracyclines from binding to the topo-2 complex. It's used widely in pediatric malignancies. In fact, there have been a number of phase 3 studies that have been done showing that it seems to be efficacious in preventing cardiovascular toxicity, but it's really only approved for use in metastatic breast cancer patients after they've received 300 milligrams per meter squared of adriamycin. And so why are we not using it more broadly in the adult population outside of the pediatric group? Well, I think it's because there was some concern when Dexrazoxane was first being studied. There was one study done in the metastatic breast cancer population by Sandra Swain. And in this study, there was a suggestion that Dexrazoxane compromised the efficacy of the chemotherapy for patients, and it resulted in a decrease in response rate for these patients and progression-free survival. Having said that, recently there was a meta-analysis published in JACC Cardio-Oncology last year by Macedo and colleagues looking at this exact question, the efficacy of Dexrazoxane in preventing anthracycline cardiotoxicity in breast cancer. This meta-analysis was exclusively in breast cancer patients treated with anthracyclines plus or minus trastuzumab in both early and metastatic settings. And as you can see, it included trials expanding over several decades, actually. There were 7 randomized trials, 2 retrospective trials, including about 2,200 patients. And the endpoints in these studies was prevention of clinical heart failure and cardiac events. And here you see the forest plot. And what's interesting to note is that Dexrazoxane did actually decrease the risk of heart failure and cardiac events, judging on this risk ratio when you combined all of the studies. So that was very encouraging. Now, what about the impact of Dexrazoxane on the efficacy of the cancer treatments that were given to these patients? Well, reassuringly, as you can see here, when they did the forest plot looking at complete response, partial response, stable disease, there was no impact of Dexrazoxane on cancer outcomes in this meta-analysis. And importantly, there was no impact of Dexrazoxane on cancer outcomes. And so the authors really concluded that in this meta-analysis, Dexrazoxane did reduce the risk of clinical heart failure. However, there was issues around the data in terms of the quality of evidence. There tended to be small studies. They tended to have different endpoints. And so their conclusion was that further randomized trials were warranted for the systematic implementation of this therapy in clinical practice. Now, one can argue that we're now using lower doses of anthracyclines in breast cancer, particularly in the adjuvant setting. But I would argue that we're still using higher doses of anthracyclines in patients with lymphoma and in the sarcoma patient population. So I still think this is very much an unanswered question. What about neurohormonal strategies? So I mentioned Dexrazoxane in the bottom left-hand corner, but what about the use of beta blockers, ACE inhibitors, and ARBs? Now, in this sort of busy diagram, I just wanted to show you a number of the key studies that have been addressing this question. These were primary prevention studies. They were all done in women with early stage breast cancer. And in these studies, women received either anthracyclines and in some cases anthracyclines and trastuzumab. They were randomized in all of these studies to either placebo or intervention with an ACE inhibitor, ARB, or a beta blocker. In some studies, such as PRADA, they had a combination of drugs. These studies all had variable endpoints, but most of them did look at prevention and drop of left ventricular ejection fraction as one of their cardiac endpoints. And when we look at the overall results, I'll just point you to this yellow box, benefit, yes, no. 3 of the studies actually did show some benefit to adding in cardioprotective therapy. However, most of these studies, the benefit was noted in an attenuation and drop in the LVEF, which in general was very small, anywhere from 3 to 5%. In 2 of the studies, and in fact, these were 2 of the larger studies, there was no difference between placebo and cardioprotective therapy, with no difference in drop in LVEF. So what are the limitations of these studies? I think, for the most part, they've tended to be small. The largest study was a few hundred patients. They've had variable exposures to anthracyclines and trastuzumab, so it's a very heterogeneous population. They use different clinical endpoints and definitions. And I think one of my greatest critiques is that it was a young population. On average, these women were in their 50s with very few cardiovascular risk factors. There's very short follow-up in these studies, and I question the statistical benefit in attenuation and drop in LVEF. Is it clinically meaningful? So if I have a patient who I prevent a drop in her LVEF from 65 to 61%, what does that mean in terms of her clinical course and clinical outcomes? Now, they've also, fortunately, done recently a meta-analysis looking at the efficacy of neurohormonal therapies in preventing cardiotoxicity in patients with cancer undergoing chemotherapy. And this was, in fact, published again in JACC Cardio-Oncology just last year. They looked at 17 randomized controlled trials in adults, 14 of them in breast cancer patients, looking at therapy versus placebo, close to 2,000 patients. And again, the primary outcome was a change in LVEF from baseline to end of the trial, with secondary outcomes such as measuring the LV size, strain, and diastolic function. They did pooled estimates for each outcome, and the follow-up ranged from 4 weeks to 2 years. So already you can see there's going to be variability, and I would argue that a follow-up of 4 weeks is extremely short. So here's the forest plot, and what you see is that overall there was the risk ratio was in favor of neurohormonal therapies. However, I would point out that again, overall the attenuation and drop in LVEF was 4%. So the authors concluded that these 17 studies showed a very modest benefit of neurohormonal therapies. Certainly the absolute benefits were less than 5%. There was substantial heterogeneity and publication bias among the existing trials, and they felt that they could not, based on this meta-analysis, recommend a routine use of these agents to reduce cardiotoxicity. And so they identified as an unmet need the need for large randomized trials powered to detect the treatment effects on clinical outcomes. And this is really what I've just alluded to. So large, adequately powered randomized trials are needed to determine the efficacy and safety of these therapies in lowering the risk of chemotherapy-related cardiotoxicity and improving clinical outcomes. And I would argue we probably need longer follow-up than the 4 weeks to 2 years that these studies included. So let's go back to our case study of this 55-year-old woman with breast cancer. If she was referred to you in consultation to consider optimization of her cardiovascular health, what would you recommend? And I would argue in 2020, certainly this sort of ABCDE approach. At this point, there really is limited evidence to support neurohormonal therapy. Just want to mention that there are a number of ongoing studies looking at cardioprotection, as you see here. SUCOR, which I believe the early results were reported at the ESC meeting just recently, is a randomized study looking at, can we identify those patients at risk using either strain or LVEF to determine if they are at higher risk and may benefit from cardioprotective strategies. And I think some of the early results suggest that maybe strain might guide us in terms of offering cardioprotective therapy to women, or at least guide us to the fact that these individuals might be at increased risk. There's another number of other studies going on. PRADA-2 for interest is looking at Entresto versus placebo in breast cancer patients treated with chemotherapy and anthracyclines. Greg Hundley is looking at a study called PREVENT, which is looking at the role of statins versus placebo. And also you can see there's ICOS-1, which is being led by the European group, and Danielle Cardinelli's group looking at enalapril in prevention after cardiotoxicity. So they would experience, it's not quite primary prevention, but they would obviously be randomized to this after they've experienced some indication of cardiotoxicity. And while all of these studies, I think, are interesting, and we certainly await to hear the results of them, I'd also like to put out that there also are some lifestyle intervention studies looking specifically at cardioprotection. And these include studies looking at web-based diet and activity intervention, as well as counseling interventions, and using technology such as mobile apps to try and deal with the younger population and lifestyle issues. So it's not, and as you can see on the right-hand side of the diagram, they're looking at weight loss, blood control measures, cholesterol, glucose, lipids, and so on. So I think this is important as we sort of look at prevention strategies, not to consider only those, cardioprotective, or neurohormonal strategies, medical therapy, but also what are some of the lifestyle and exercise interventions that we can consider. So this is my take on primary prevention strategies in 2020. Is it ready for prime time? I think we need larger multi-center, adequately powered randomized trials in this area. We need longer follow-up to see what the clinical outcomes are. We need to include patients with comorbidities and to risk stratify these patients. I really do think that the studies that have been up to date were interesting, but they did include mainly healthy people. And that's perhaps not the population that we should be focusing on. And certainly, again, in North Carolina, I see people here who don't exercise, are overweight, they have hypertension and diabetes, and then we give them cancer therapy. This is the population I think is at high risk, and we need to be including them in these types of studies. We need to standardize definitions, whether it's a drop in LVEF or whether it's changes on a CMR. I think there's too much heterogeneity in the definitions that are used, and we need adjudicated cardiac imaging. And I already alluded to this, clinical endpoints that are clinically meaningful. Is it clinically meaningful to say that you were preventing a drop in your EF 4 to 5%? Or should we be looking at harder endpoints such as prevention of heart failure? Of course, these are much harder to show and require larger studies and longer follow-up. And then I do think we should start thinking about incorporation of biomarkers in risk prediction. So not ready yet for primary prevention, but I think we're on our way. And I think this is really a call for more research in this area. So where are we now in terms of cardioprotection therapy? And I just wanted to highlight for you that the European Society of Medical Oncology recently came out with this position paper on the management of cardiac disease in cancer patients throughout their oncological treatment. And what you'll note in this diagram, and I know that this does not apply to all cancer therapies because it's specifically addressing those cancer therapies that potentially impact, the cardiovascular function in terms of drops in LVEF. But if you look at this diagram, you'll clearly see that they clearly recommend cardioprotection for patients who have low LVEFs at the beginning of their treatment, such as on the very left-hand side of this diagram. They also say that you should consider cardioprotective therapy for those who have very borderline heart function if there's no other alternative cancer therapies that are not cardiotoxic, which is this group here. Obviously, for those patients who go on and develop cardiovascular toxicity, they recommend cardioprotection at the bottom of this diagram, but I'll highlight that for patients who are starting treatment with an LVEF of over 50%, we are not at this point, nor are the position papers recommending upfront cardioprotective medication. I would still say, though, at this point, and for all our cancer patients, we should be advocating healthy lifestyle and control of their risk factors. And so this is what I think cancer care in 2020 should look like. We have clearly improved in terms of our ability to identify cancers and subtypes of cancers, but as oncologists, what we tend to focus on is what cancer therapy am I going to give this individual, whether it be the traditional cytotoxic chemo drugs or radiation or now immunotherapy. This is what we try to plan, and then we focus on giving that to our cancer patients to improve clinical outcomes. But that is really only part of the picture. What we need to be doing in 2020 is we need to be considering that individual's risk factors for cardiovascular disease, any previous cardiovascular disease, smoking history, whether they're elderly, obese, and inactive. Because it's all of these things combined, not just the cancer therapy and the impact of that on the cancer, but all of these things combined, I think, will certainly lead to improvement in survivorship. And what we don't want to do is we don't want to improve cancer outcomes only for these patients to then go on and develop significant cardiovascular morbidity and mortality. And so I think in 2020, we need to be better at risk stratification up front when these patients come in. And certainly there's a lot of work going on in this area. And then when patients are going through their treatment, although at this point there's no evidence to suggest cardioprotective medication up front, I still think we can use the sort of ABCD approach in terms of lifestyle modification and controlling some of these risk factors, whether that means controlling their hypertension or their diabetes, stop smoking, and encouraging our cancer patients to be more active. And in fact, there was this nice statement that came out in Circulation last year, looking essentially at that exercise for cancer patients, I think, throughout their treatment and certainly beyond completion of their treatment. And with that, I think that's the end of my talk. Thank you again for asking me to speak to this group, and I certainly would be open to questions.
Thank you so much, ma'am. Now I request our chairperson to please moderate the question and answers. I will just display the screen.
Thank you, Professor Susan Dent, for such a nice lecture. And before these slides are there, as you already said, the concept of ABCDE is a very, very nice concept which has been alluded by you. I just had one question before we started. At what ejection fraction would you hold trastuzumab at inception? Is there any?
Yeah, so that's a very good. So it's a very good question. So, I think, and of course, I think you're speaking to someone who has a lot of bias, because I truly believe, and actually it's more than belief, that trastuzumab has improved not only the disease-free, but overall survival in women with early stage breast cancer, and improves outcomes with those with advanced disease. So, there was a study done not long ago called Safe Heart, where they looked at treating women both with early and advanced breast cancer with HER2 targeted therapy with ejection fractions in the 40 to 50% range, and with appropriate intervention with cardioprotective medications, they were able to actually treat those women and get them safely through their treatment. And I have to say, I currently have a woman I'm treating whose ejection fraction is bordering 40%. And she had an H1N1 induced viral cardiomyopathy several years ago and has been left with permanent LV dysfunction and is on a number of medications. And what we've been doing is we've certainly continued to treat her. We watch her very closely, and we do her cardiac biomarkers before every cycle, and they have consistently remained low. And so I think, when you see these patients, when they're below 50%, A, you need to work with your cardio-oncology team. You need to absolutely have them on board. And B, you have to look at what are the potential clinical benefits of that therapy, and if they're high or not. For example, if I have someone with a very small HER2 positive breast cancer, and I think her risk of recurrence is low. Let's say it's 1 centimeter, it's ERPR positive, it's grade 2, then I think those individuals, particularly those who have borderline heart function, we could potentially look at different types of therapy or even a shorter course of therapy, although that's a whole other area. But for those women who have high risk breast cancer, multiple nodes positive, HER2 positive, and who have borderline heart function, I think that we probably can, for the most part, safely give them HER2 targeted therapy, non-anthracycline based HER2 targeted therapy, if we work closely with our cardiology colleagues. But they have to be watched closely. And, it may mean that they may have to stop prematurely, or they may have to have short breaks in their treatment. So there's a lot that needs to go into those discussions, but really it is, what is the clinical benefit in terms of cancer outcomes versus the risk in terms of cardiovascular outcomes? And that's where that does require, I think, individual discussion with the patient. But certainly I've done it in high risk patients.
So I gather that if you have an ejection fraction of 50%, then you can go ahead. Between 40 to 50, you have to individualize and probably do it every time. There are a host of questions which I see in the chat box, and I think Professor Dent will go very quickly through them. Is there any role of dexrazoxane after subclinical injury or clinical injury due to anthracycline? This is from Dr. Vivek.
So I'll comment on the second aspect of that question first.
Okay.
So Dexrazoxane has been around for a long time, and I think one of the problems is it's been abandoned by different drug companies, and so the availability of it has been compromised by that. There has been some resurgence in the interest in it and again in the pediatric population, where it's being used now. My understanding is it is not cheap. I don't know the exact cost here in the US, but cost is an issue. And it is because of its the current FDA label of only being useful, or I shouldn't say useful, the FDA label saying it's approved for women, with breast cancer after 300 milligrams per meter squared of anthracyclines. It typically has not been used in the adjuvant setting, nor I think there may be issues in the States about getting coverage for the medication outside of the FDA label. So I think that this is a drug that does have potential benefit, but I think it needs to be studied in a prospective study, probably in a population such as sarcoma or lymphoma, where these patients are exposed to higher doses of anthracyclines. In the breast cancer population, where we use adriamycin, they usually don't get more than 240 milligrams per meter squared. And so it's probably not a higher risk population, but if you look at sarcoma and lymphoma patients, they're getting up there in terms of their anthracycline. So I think the first question, I would say yes in the pediatric population, but in the adult population, I think you'd need further studies to be done, looking at those individuals who still have cancer that receive high doses of anthracyclines.
There was a corollary to this by Dr. Indu. She says, any study of dexrazoxane with radiation for left-sided breast cancer? If it can be answered.
Good question. So dexrazoxane with left-sided breast cancer and reducing that, not that I am aware of. I think, but having said that, if you look at you'd have to go back. If you look at the meta-analysis, I'm sure obviously there were studies in there that had patients with left-sided breast cancer. I do not have, that information drilled down to that. I'm sure you could glean that data out of the studies that were done, but I don't have those numbers off the top of my head.
Okay. Is there any role of coenzyme Q10 in anthracycline-associated cardiotoxicity?
Not that I am aware of. I'm certainly open if there's anyone else on this conference who has information on that. I am not aware of any data to support that.
Madam, any difference in cardiotoxicity due to equivalent doses of different anthracyclines? as well as the response to treatment or prevention from protective agents. You mentioned the level after which there can be a problem, but any equivalent dose?
Yeah, I don't think so. So, you know, in the US, adriamycin is used, in Europe and in Canada still, well, up until recently, epirubicin was used. But I think when you look at the sort of milliequivalents, I don't think there's been any evidence to support that at that equivalent dose that there's any significant difference in cardiotoxicity. I think it's just, you know, epirubicin, you can go, the doses are higher, but it's milliequivalent, no.
And this is the obvious question which is asked most of the time whenever you talk of cardiotoxicity. Echo, where you can have a physician bias, and MUGA, where would you rate both of them? Is any one of them better?
Yeah, so this is interesting. So I haven't ordered, I do not generally use MUGA scans anymore. One of the reasons is because of my concern, you know, with radiation exposure with MUGA scans versus echo. So we tend to do echoes here. But in fact, when you're looking at, if you want a precise number for left ventricular ejection fraction, MUGAs tend to be a bit more accurate than echocardiograms, but echocardiograms is what we use. And also there's a whole issue around global longitudinal strain and being able to get that parameter with an echocardiogram. Having said that, that's a whole another topic about the value of obtaining a global longitudinal strain, but we do that on our patients as baseline, and then we follow the global longitudinal strain as they go through their treatment to see if any difference or any drop within an individual patient. And as you know, there's some evidence to suggest that's a precursor to left ventricular dysfunction if you see the GLS dropping, and that may make you think earlier about maybe cardioprotective strategies, but there's no evidence at this point that GLS, that number, should dictate the cancer therapy that you offer these patients.
Okay, this question I think you discussed in the talk. Can we have the next question, please?
What is the ideal? Oh, okay.
Yeah.
So which one?
Yeah, this is the question. After anthracyclines for follow-up, which is the frequency of doing echo and till what time?
So this is also, there's a lot of debate on this. The ASCO guideline recommends that you do a echo 6 to 12 months after completion of adjuvant therapy, and then it's clinically indicated. Some of the European guidelines recommend that you do that, and then maybe at 2 and 5 years. I would argue that we really don't have a lot of level 1 evidence to support doing echoes long-term. It's different in the pediatric population where they clearly have guidelines based on long-term follow-up data of patients, you know, where they do them routinely. But in the adult population beyond that 6 to 12 month echo, maybe one at 5 years, I think it's really only based on symptoms. And so we do need more literature in this area. We don't have a lot of good quality data to support routine cardiac imaging in that patient population.
Well, thank you very much, Professor Susan. We would have gone on and on. I think probably we'll continue to discuss in the panel discussion. So over to you, Kashish.
Thank you so much, sir. Thank you, Maan, for the wonderful session. We'll move on to the panel discussion. Our moderator for the panel is Dr. Hisham Ahmed, cardiologist from Kochi, and the panelists are Dr. Anuprita Dadi, internal medicine specialist, Mumbai, Dr. Avirab Gua, cardiologist from USA, Dr. Munna Das, cardiologist from Kolkata, Dr. Mansi Sharma, medical oncologist from New Delhi, Dr. Nidhi Tandon, medical oncologist from Bangalore, and Dr. Shevanti Limai, medical oncologist from Mumbai. Over to you, sir.
Yeah, can you hear me? Yeah.
Yes, sir.
Yeah, I just can just share my slides, please. Thank you very much, and good evening, everyone. And then I think after such an exhilarating keynote address, I think some of the concepts which Dr. Dent has discussed will find considerable overlap in what we're about to discuss today. And I think that's a great thing. I think it serves to reinforce some of the key concepts that we learned during her great talk. So Our shared goal in cardio-oncology, obviously, is to attain a balance of optimum oncological therapy, efficacy, and at the same time minimizing cardiovascular morbidity and mortality. And so essentially, we are looking at early recognition of cancer therapy-related cardiac dysfunction. And over the last few decades, we've sort of expanded our toolbox to recognize cardiac injury and CTR-CD, essentially cancer therapy-related cardiac dysfunction. So there has been a focus on early detection, and there has also been a focus on what to do with that information and how we can optimize that information before and during therapy to optimize the clinical outcomes of our patients. And let me welcome the audience to this panel discussion. We have a very distinguished panel to discuss these issues today, and we're going to discuss the concepts of cardiac imaging and biomarkers before chemotherapy, as well as during chemotherapy. So as has already been introduced, we have a distinguished panel consisting of medical oncologists and cardiologists and internal medicine specialists with tremendous experience in the field. So this is what we'll be discussing today, and we'll be looking at biomarkers and imaging of cardiac status before and during oncotherapy. So just to maintain the flow of discussion, I thought we would take a prototype patient that we see in our clinic every day, and I'm sure this is a patient whom we see every day, a patient of breast cancer who's just being prepared for anthracycline-based chemotherapy plus minus HER2 targeted therapy, as the case may be, with trastuzumab or pertuzumab. So let me initiate the discussion let me start with Dr. Sevanti Limaye. And I thought maybe if you could let us know that such a patient comes to your oncology clinic, and as your initial step, what would be your concerns? This is a patient whom you're planning to embark on anthracycline-based chemotherapy plus minus HER2 targeted therapy. I would like to know what would be your approach in terms of assessing the cardiovascular risk, or what would be your cardiovascular risk assessment in this patient, and what would be your workflow in your practice? Over to you, Dr. Limaye.
Thank you. Thank you so much. And again, ditto the wonderful meeting and the great talk by Dr. Dent. My approach to any such patient is always to take into account what kind of comorbidities we are dealing with. And a baseline to the echo is one of the most rudimentary information that you really need. So basic information is a 2D echo and the ejection fraction of that patient, but obviously the risk assessment also involves the other comorbidities. And if at all in doubt, patient selection is critical, if at all in doubt, involving a cardiologist. Because I work, I'm fortunate to be working at a multi-specialty center where a multidisciplinary care is a norm. And so very easily involving one of my colleagues running the case by is how I would manage this, any patient.
Thank you, Dr. Limaye. I'd like to focus on Dr. Sharma now, Dr. Mansi Sharma. Dr. Limaye has clearly outlined her workflow in managing the initial process of evaluating such a patient in whom such a regimen is about to be started. What I would like to know from you is, could you contextualize this workflow against the backdrop of the current recommendations of let's say the ACO recommendations of cardiovascular assessment of such a patient? Could you just take us through very briefly what are the current recommendations pre-chemotherapy? Dr. Sharma.
So history taking is paramount. Looking at risk factors is important. It's especially important to look at obesity, diabetes, hypertension, see whether the patient is already on treatment for these particular comorbidities or not, whether she's already taking any medications before that. Another important thing which I'd like to probably add is we look at baseline ECGs, and also look at all the various medications that the patient is on with respect to drug interactions, QT prolonging medications. do a comprehensive risk assessment of the patient, then go ahead with further investigations to see what the baseline cardiac assessment would be, again, which includes a echocardiogram and an ECG. And if needed, go ahead with further studies. The role of cardiac biomarkers is still undefined. Certain guidelines do recommend it. Certain guidelines don't recommend it. Follow-up again is very uncertain. It depends on the basis of what those reports show us.
Thank you, Dr. Sharma. So obviously the natural, the next step in the sequence would be this patient lands with a cardiologist in either of your institutes and would be subjected to a comprehensive cardiac evaluation pre-chemotherapy. I'd like to address this question to Dr. Munna Das. Such a patient has come to your clinic for a cardiac assessment. Could you just take us through the steps of how would you assess such a patient pre-chemotherapy, a patient who is being planned for such a regimen? Dr. Das, please.
Thanks for your question. The only, I actually agree to our two previous speakers who has addressed the flowchart of how to assess such a patient pre-chemotherapy. But two or three things I want to re-emphasize is basically the echo assessment should be a bit more objective in terms of using a volumetric method if it is a 3D echo, or if it is a 2D echo, then using the Simpson's rule, so that with a good endocardial border tracking, so that you have an objectiveness of the LVEF. Plus, in addition, you need the same operator who is doing the echo to do the serial echoes also. And you should also have your offline recordings to compare the baseline with the serial follow-ups later on that we do in our practice. So I have my senior echocardiography consultant colleague who is well versed in doing such echoes, and I also join him in the echo room if such a patient comes to have an initial assessment, and then on follow-up, I myself along with Dr. Vivek, we discuss the issues and then move on. And further to add to this is basically the patient will not only benefit from a chemotherapy schedule for his cancer, for her cancer, but also what has to be emphasized is a comprehensive cardiac risk assessment with preferably a risk score to add to the objectivity, and treat this patient from the other comorbidities, hypertension, diabetes, obesity, cholesterol lowering, and maybe aspirin or any other antiplatelet as required for in the setting of established cardiovascular disease, or the patient has a CABG or PCI intervention done. So these patients can have a improved cardiovascular quality of life and quantity of life.
Thank you, Dr. Das. Could I have your comments on, would you prefer to obtain a baseline global longitudinal strain in these patients? We are aware that these strain values do not, in fact, have prospective data in terms of, intervening in terms of changing the therapy for a patient. But as a matter of your echo protocol, would you consider obtaining a baseline strain?
Yeah. But that is obviously in the guideline itself that a GLS should be measured, and it's a more objective parameter to compare. And but in our routine practice, honest to be said, we rely on LVEF alone, and GLS obviously should be used.
Right.
Can I say something? Can I add something?
Please.
So can I speak for a minute?
Could we just continue with the panel discussion, and can we invite the comments later on? Yeah,
sure, that's fine.
Yeah, thank you so much. So as Dr. Das said, I think this patient needs to undergo a structured cardiac evaluation, and of course, imaging being one of the primary components of the structured evaluation. I'd like to turn over to Dr. Avirup. And we've discussed regarding obtaining the baseline imaging parameters with which we would like to follow this patient longitudinally during the course of therapy. Dr. Avirup, what are your comments on obtaining baseline biomarkers such as troponin and NT-proBNP? Could you take us through the significance of getting these markers as baseline before therapy? Dr. Avirup.
You guys can hear me, right?
Yeah, I can hear you. Yeah,
Okay.
Go ahead.
So thank you so much for the invitation. And I have to first agree with the whole panel so far. I think excellent discussion. And I think, as Dr. Das said, in addition to the 2D and the quality of the objective echocardiogram, certain things which come before a systolic dysfunction should also be included in the measurement of possible toxicity like diastolic dysfunction. It is contested. We can have a long discussion, but I would say that that is another parameter which you get in echo, which you don't get in a MAGA scan, which I think was asked earlier, even to Dr. Dent. So moving to what other things which you do during cardiac evaluation, I think the ESMO guidelines which Dr. Dent showed, and then there is a recent document in European Journal of Heart Failure which has a structured list of things to obtain. And I would say anybody starting a cardio-oncology practice can just take that list and make a objective evaluation, a standard evaluation, so that, because in a busy practice, you may skip a question or not. Here you'll have a list of questions, and then you can even calculate scores, which give us the risk of potential toxicity afterwards. So the one which has the least established data, or something which is not very frequently done, is to get biomarkers, which needs I would say currently a clinical gestalt of how you would do it. So what the medication is how I would think of biomarkers. So even though it has been shown that what anthracycline does is cause apoptotic changes, or the cells actually die, versus if you see the changes which you see with HER2 new inhibitor, where the changes are reversible, where heart failure is more of a phenotype which you see, maybe a BNP based approach is probably better, versus anthracycline, a high sensitivity troponin is better. Now, having said that, high sensitivity troponin is hard to get, and I think as and when these are easily available, it's not probably a bad idea to see what clinical practices and try with each of these agents. Start with troponin-based approach in anthracycline patients, and BNP-based approach in the HER2 new patients. And then as and when we getting the echocardiograms, which are as per guideline, we can compare and see if the delta is worth doing this in the long term, because we don't know if the delta is worth following. It might add to cost, but not much, and might add to the burden of what the patient needs to go through, much, and not add to the benefit. So I think, again, open for discussion, but not really set in stone yet.
Thank you, Dr. Guha. So I take it that the biomarkers are not ready for prime time yet, but then as more data comes through, probably we'll be on much firmer ground to assess the prognostic significance of biomarkers. I'd like to turn the attention to Dr. Tandon, Dr. Nidhi Tandon. So let's dial the clock forward. Let's say that after the sequence of evaluation of baseline imaging, plus minus biomarkers as the case may be, let's dial the clock and say that the patient has been initiated on therapy. Could you tell us something about after initiation of therapy, what would be your surveillance interval? So how often would you involve your cardiology colleague in your practice, in your institution? So once the patient has been initiated on therapy, what would be your surveillance intervals be? And how often would you bring your cardiology colleague into the surveillance process? Dr. Tandon.
Thank you for the invitation. My answer to this question is that it depends on whether it is a type 1 agent or a type 2 agent. Type 1 agents like anthracyclines would need a repeat assessment after cumulative dosage of 240 mg per meter square, and then after every 50 mg meter per meter square increase, and even after completion of therapy every 6 to 12 months. Whereas if it is a type 2 agent like anti-HER2 new therapy, then we need an assessment after every 3 months. What is important to note is that we should have the same method of assessment what was used at the baseline. For example, if we have used a 3D echo versus a 2D echo at baseline, it is better to follow up the ejection fraction with the same parameter. If a GLS or a troponin value was used at baseline, that could be added as well to assess subclinical damage. And whenever the left ventricular ejection fraction falls to less than 10% or to an absolute value of less than 53%, or if we are monitoring the subclinical parameters and the GLS shows an absolute reduction of more than 15%, or there is a rise in troponin value, in that case, cardiology needs to be involved again.
Thank you, Dr. Tandon. So I think that's a great overview regarding what should be the surveillance interval like and what factors should be looked at. A quick question to Dr. Munnadas as one of the cardiologists in the panel. So the treatment has been initiated in this patient, and of course, the patient is visiting your clinic at pre-prescribed intervals. Could you just sum up quickly, what are the parameters which you would really focus on in monitoring such a patient during therapy? So you've already discussed what happens before therapy, the parameters which you looked at, and do you have any specific protocol in the sense on following these patients up when they come for interval surveillance visits?
Thanks again for the question. As just I had enumerated in the first question itself, so my previous speaker also mentioned that the same method of measuring the echo parameters should be used, and it should be the same operator so that the intra and inter-observer variability can be decreased. And furthermore, the LVEF is the most important parameter that we look at. But apart from that, we also look at other features like your strain at times and your diastolic function. But mind you, the question of diastolic function as a prognostic indicator is has some caveats. In particular, it depends on loading conditions, just as EF. And if this patient might have a diarrhea the other day, then the diastolic function parameters can be deranged. Most important is the serial. The serial measurement is more important to me than absolute value, and the patient symptoms. So if this patient is having symptoms with even a drop of 5%, I will be wary. I will reinstitute my therapies, ask my colleague to withhold therapy for at least 3 weeks to allow the EF to come up. And if the patient is asymptomatic, then obviously with judicious monitoring, we can still continue therapy unless the EF has gone below like more than 10% or even with trastuzumab less than 40%.
Thank you, Dr. Das. I think the point which you raised regarding factors such as hydration in these patients who are on chemotherapy, and the fact that they can influence your measurements of LV volumes and therefore LV function metrics on the echo. And I think that point is well taken. I think it's probably better to reassess probably after another one or 2 weeks when these loading conditions are more stable to have an accurate quantification of LV volumes and LV function. A quick question to Dr. Avirup Guha. So during monitoring of these patients, what would be your red flags? What would be your red flags in the sense, when will you say, hang on, I need to talk to my oncologist. I need to get him or her on the phone, and I need to talk to him or her regarding this patient. So what would be your red flags during the monitoring process?
I think the clinical diagnosis of heart failure is what I think everybody is looking for mostly. So, as long as you've seen them for the first time, and you have to remember, their ECOG situation might be make them look really sick. But if they're baseline looking sick, but you know what their baseline is, from there, asking questions specific to heart failure, orthopnea, PND, and things like that is obviously the first clinical question which you need to ask and have answered. Then obviously in terms of imaging, you would have a delta, and I think one of the panelists put in the exact numbers, and I think GLS less than -15 or EF drop, depending on the kind of agent, if it's less than 40 or more than 10% dropping EF from baseline. And then in terms of biomarkers, if you are following it, one of the most sensitive biomarkers for heart failure is BNP. So if that starts going up, if it doubles, and based on the fourth universal definition of MI, if greater than 99th percentile increase in the troponin, whichever troponin you're using, are sort of the 4 or 5 things I would be very worried about and get my oncologist on the phone to see if we need to do something to the therapy or just hold it for a little bit till we get them on track. One thing to remember for every single cardio-oncologist, the goal is to get them through the whole therapy. If the goal is not to hold therapy, the goal is to hold it for the least amount of time possible.
Thank you, Dr. Arup. I think you've summarized that aspect very well. I'd like to focus on Dr. Limay. So the patient undergoes therapy. And obviously, I think from the previous discussion, the feedback from our cardiology colleagues is extremely crucial in understanding how the patient is behaving as the therapy progresses. Let's say that you do get a call from the cardiologist and says, you know, we might need to consider stop therapy in this patient who's on trastuzumab, sequential therapy after anthracycline. What would be your process be? What would be your thought process? Because it's quite clear that a lot of the adjuvant trials have shown that the survival benefit in these patients with trastuzumab is considerable. So what would be your process after you get that call, which says that, you know, we should probably think about stopping trastuzumab? What are your thoughts on that?
So, you know, the position of heart is at the heart of everything. So obviously the cardiologist wins. I'm married to one, and so you know my equation.
Yeah.
So of course here I would really give importance to what my cardiologist friend has to say. And there is this cardiac remodeling process. So the hope is that with the medications, the patient's cardiac dysfunction recovers. And if it is trastuzumab induced, we know that it is reversible. And sometimes we do have issues where the patient has both anthracycline and trastuzumab, and the picture is slightly unclear. Even there, the management would be similar, and a close follow-up for the patient, and holding the drug is the norm. One would obviously look at the guidelines and make sure that we don't restart if the patient is not able to recover back to the baseline. And re-challenging should be done with great thought and proper follow-up. Wherever we re-challenge, we have to really work shoulder to shoulder with the multidisciplinary team and involve the cardiology team equally so that the patient gets proper care. Usually, even if I re-challenge, I monitor the patient prior to each dosage, unless we have gone through several dosages and the patient has done well. That's when I am able to relax a little. But again, each one of the visits is looked at very, very carefully before dosing the patient.
Yeah,
Dr. Hisham, we have just 5 minutes more.
We'll be winding up.
Is also there. She's a
cardio-oncologist
at
yes. So that was a good timing, because my next question was to Dr. Anuprita Daddi. So Dr. Anuprita, as an internal medicine person and closely involved in the cardio-oncology, you are uniquely situated to have a very holistic assessment of the well-being of such a patient. So during a regular follow-up of these patients, what would trigger you to alert the oncologist or the cardiologist to say that let's have a relook at this patient because of the current clinical status of this patient? So during the longitudinal follow-up, Dr. Daddi, what would be your triggers to initiate a referral to the cardiologist or the oncologist once again?
Hello, good evening, everybody. Can you hear me?
Yes, we can. Go ahead, please.
Ishmat, even though I'm in internal medicine, I've been practicing cardio-oncology since last more than 10 years at Tata Cancer Hospital in Mumbai. And we had initiated a cardio-oncology clinic from 2009. So it's whenever in our institute, if there is any such issue, it's referred to a cardio-oncology clinic. Now, regarding this patient, like you said, the patient is on trastuzumab, and the EF has come down. So if we will start with AC inhibitors, and we will look to it that the chemotherapy is not interrupted and patient completes with chemotherapy, because that is the more important thing. The patient completes the cancer therapy with the help of the preventive measures. So given a gap of this chemotherapy, we will give a gap, continue with AC inhibitors, and then we will reassess with the echo, and again we'll continue with the chemotherapy. Now, what we do is we generally, for such patient, we keep a close monitoring, that we inform the oncologist that after next cycle, please send back the patient to us. Also, it is very important to ask the history to the patient for what obviously effort tolerance or breathlessness or any other thing. Like generally in our country, patients don't do any physical activity, so they will say, I don't have breathlessness. So it is very important to initiate a good talk with the patient to ask their complaints, which will be red flag to us. Like the patient history is very important at this point. Also with global longitudinal strain, as it said, we have got baseline global longitudinal strain, and we will compare with the baseline global longitudinal strain. If more than drop is more than 15%, obviously we will again inform the oncologist and the cardiologist. So that's it.
Yeah. So thank you very much, Dr. Dedi, for your perspectives. So I think for the lack of time, I think, and since we would like to take some questions from Q&As from the audience as well, let's summarize that cardiac imaging plays a pivotal role in addition to a very carefully taken clinical history and clinical examination. And I think it's clear that there's very encouraging data longitudinally that some of the cardiac monitoring parameters, such as the strain, the LV ejection fraction, both the 2D and the 3D, and in certain instances, cardiac MRI, but that's subject to availability. But the data is strongest in terms of imaging for echo. And the biomarkers, the data is slowly evolving. There's been some interesting data which was published in the American Heart Association Jan 2020 regarding the prognostic role of biomarkers, so of the BNP and troponin. So the role of BNP and troponin is getting more and more validated, and I think we're about to see some exciting data as in the future. So let me just conclude this panel discussion now, and we would be happy to take any questions from the audience, and we would be happy to direct them to our panelists. So if we could have the questions, please. So this is the first question. So the first question describes a diabetic patient with non-Hodgkin's lymphoma who has experienced chest pain and elevated cardiac markers without a drop of LV ejection fraction, and there are no ECG changes. Would you consider it an immediate cardiotoxicity or a non-ST elevation MI? Could I ask Dr. Avirup to take this question, please?
Thank you for the question. And I think this is a very clinical question. Actually reminds me of one of the questions which we made for the ICOS exam. Anytime you have a patient with chest pain and biomarker changes, you think of coronary disease first. That is a standard thought process. So you rule out coronary disease. Again, the delta of the troponins which you'll get will help you with that. And the clinical picture will help you with that. And then just clinically talking cardiology, not cardio-oncology, you can miss a small lateral wall motion abnormality on an echocardiogram. Often happens with a small branch vessel disease. So, and there's a concept of shared risk factors, which is very well clear between cancer and heart disease, and because of which normal patients with cancer can have NSTEMI. So think of NSTEMI first, and then we can go back and think about cardio-oncology.
Thank you. Could we have the next question, please?
So any role of angiography in such kind of situation, Dr. Avirup?
I think that is again based on the Indian, American, and European guidelines. If you think this is an NSTEMI and the delta troponin is going up with the patient having chest pain, the next step is doing an angiogram. I mean, now having said that, now you presented a non-Hodgkin's lymphoma patient, so you might have to sort of remember certain challenges you might face if they've had radiation therapy to your chest. But that again comes later in the cath lab.
So we have the second question from Dr. Vivek. So what is the role of stress echo for risk stratification? The resting echo may be normal, but stress echo, can it possibly show at-risk status? Could I have Dr. Munna Das take this question, please?
Hello, yeah. So this is a very valid question. To answer this question, what we need to know is that our baseline echo parameters are well validated in clinical trials, but for stress echo as a prognostic marker in predicting cardiotoxicity long term is not well validated, but we can pick up incidental significant coronary disease on stress echo, and at times stress echo with a subnormal LVEF on post-exercise or on dobutamine stress can help us to identify patients at risk. But again, that parameter as a prognostic marker for cardiotoxicity to the anthracycline agents, etc., is not well validated.
Yeah, thank you, Dr. Das. We have another cardiology-related question, so I would like one of the cardiologists to take this question. So, is there any special consideration for those patients who have rheumatic heart disease with normal ejection fraction, but mild mitral stenosis or mild mitral regurgitation detected on the 2D echo? Is there any parameter to decide the permitted fluid intake of these patients when they undergo pre-specified chemotherapy protocols? Dr. Avirup, could you take this question?
I think when you have mild MS in a rheumatic heart disease patient, I would just follow them clinically. I wouldn't do anything different.
Yeah, I would agree. So we have another interesting question. So in the time that the patient is off trastuzumab, will using lapatinib be a less cardiotoxic agent? Would that fill this sort of vulnerable window? Could I ask Dr. Mansi Sharma to take this question?
So it depends on what we're looking at, whether we're trying to treat the patient in the adjuvant setting or a curative intent setting, or whether we're trying to treat the patient in a palliative setting. We'll also look at, if it's in a palliative setting, we'll look at the risk benefit. We'll see what the burden of disease was, whether we actually think that the disease is going to progress in that small time that, we take the patient off trastuzumab. Now, trastuzumab is known to have a reversible cardiac failure. So recommendations are you wait for 3 weeks, unless and until the patient has been like really symptomatic, had a symptomatic CHF. I would suggest just waiting for 3 weeks, seeing whether the ejection fraction gets better or not, and then taking a decision after that.
Yeah.
So probably no.
No, yeah, thank you. We have a question on 5-fluorouracil. So cardiotoxicity, 5-fluorouracil can be difficult to manage, can be very bad. So is there any way of predicting? So the question is not managing, the question is of predicting the risk to the same. Dr. Das, would you care to take this question?
Yes, actually, this is a question, additional question to what Dr. Vivek had asked. Actually, this is one issue where your stress testing can be of help. A stress echo in patients non-ambulant, or even a exercise stress test can, patients who are ambulant and have good effort tolerance, can help us predict these patients who have significant coronary artery disease are at higher risk of having 5-fluorouracil induced cardiotoxicity in terms of cardiac ischemia.
Just to add to what Dr. Das said, from the oncological perspective, if the patient is developing severe myelosuppression or mucositis because of 5-FU, we can test for DPD deficiency, which metabolizes 5-FU. And if the patient is DPD deficient, then another risk factor for increase in cardiotoxicity.
Thank you. Just a follow-up question. Would you consider that as a blanket strategy for all patients, or would you wait for a clinical trigger to perform that test?
No, till now, DPD testing at baseline has not been studied. There have been few studies where they have tested everybody, but it has not been found to be clinically useful. So only if the patient develops severe grade 3 or 4 adverse events in form of myelosuppression or mucositis, which is out of proportion, then we do a DPD testing.
Thank you.
Yeah, I think we have come to an end, and I
Yeah,
think we need to go to the next session.
Yeah. So thanks, Dr. Vivek. I think let me thank the panel. So it's been a tremendous experience interacting with this distinguished panel, and I think we've managed to address a lot of the concerns of monitoring patients on chemotherapy before and during therapy with the available tools of cardiovascular imaging and biomarkers. I thank the panel and I thank the audience for interesting interaction. Thanks, Vivek.
Thank you. And I placed a PDF in the chat if people were interested. This was the most recent state-of-the-art review in JACC about biomarkers, because obviously there's not data to follow them. But if you wanted to just read the paper, it has everything up till 2020 in it.
Yeah. Thank you, Dr. Guha. Thank you very much.
Yeah, Kashish, over to you.
Thank you so much, sir. We'll now move on to our case presentation. Our chairperson for this session is Dr. R.R. Kasliwal, Senior Cardiologist from Gurugram. Thank you so much, sir, for agreeing to chair the session. Over to you, sir.
Thank you. Good evening. I'm Ravi Kasliwal. I chair Clinical and Preventive Cardiology at Medanta, the Medicity. And I must say the previous, I'm sorry, Dr. Ahmed, I didn't want to butt in, but it was a really very interesting program. So excuse me for that.
No, that's all right. That's all right.
But really fantastic. When I started 4 years ago with cardio-oncology, people used to actually snicker at my back, and now the whole thing. And there's a clear difference when we started doing just ejection fractions to now when we routinely for every patient do a global longitudinal strain, a E by E prime, and tricuspid regurgitation for PA pressures and IVC. It's made a lot of difference. However, as we are running already short of time, this is a cardiac transplant for chemo-induced cardiomyopathy. May I first invite Dr. Uday Kiranane, please, to speak on this very interesting subject on cardiac transplant for chemo-induced cardiomyopathy.
Hello.
Good evening.
Good evening. Good evening, everyone. So today I'll be just presenting a gist of 4 cases in whom, because of chemotherapy-induced cardiomyopathy, they underwent heart transplant. So I'll have my slides.
So will you be sharing your screen, sir?
Yeah. I'm just going through. Do we have my slides for backup or something?
Sir, I will just project the same.
Yeah, sure.
As the slides come, if you want to say something, Dr. Uday?
Yes, sir. So basically, this is a paper published in the Indian Journal of Thoracic and Cardiovascular Surgery recently, a couple of months back. So basically, this focuses mainly on which patients we have to select for cardiac transplant. So I'll start up. So this is a paper reviewing the transplantation for chemotherapy-induced cardiomyopathy. It's a case series and it has a little review of current practice. So we'll proceed. So I'll start with two cases. Case 1 and 2 are mainly young males. It's a 19 years male. He has no previous history of cardiac disease, no cardiac risk factors. So he had a Ewing sarcoma of the left scapula 3 years back. Surgical removal plus chemotherapy with doxorubicin. Cumulative dose of doxorubicin was around 375 milligrams per meter square. Now he presented to the cardiologist with a shortness of breath, New York Heart Association class 4, which was class 2 1 month back and progressed to class 4 within a span of 1 month. And he had palpitations for the last 3 months, most probably related to the volume overload. and mitral regurgitation. Next slide. So he was evaluated. ECG was showing left ventricular hypertrophy with T-inversion in the anterolateral leads. Chest X-ray was showing cardiomegaly. The biomarker BNP was grossly elevated. And 2D echo here, you can see a short axis still frame with thinning of the walls, dilated left ventricle with lot of sec and all. And the LVEF was around 22%. So he was diagnosed as chemotherapy-induced cardiomyopathy. And initially he was started on medical management with the AC inhibitors, beta blockers, diuretics and all. But it didn't work out well. So he was then worked up and advised heart transplant. So coming to the case 2, this is also a 35-year-old male, localized Ewing sarcoma of the lower limb. He was also given chemotherapy with anthracycline and ifosfamide. So the doxorubicin cumulative dose was around 400 milligrams per meter square, and everything was well. But after 4 years, he started developing similar symptoms of shortness of breath and palpitations. And it was also again confirmed with biomarkers, ECG, chest X-ray. In him, they could medically manage him for about 6 months. Then symptoms gradually worsened and repeated admissions. So he was evaluated and advised for cardiac transplant after obtaining a negative PET CT. So post-transplant, now after 2 years, he is doing well. So case 3 and 4 are a little different. These are female patients, breast cancer patients. So case 3 is a 58-year female, but she had no previous cardiac histories or no risk factors for CID. So right-sided breast cancer, stage 2A. Initially mastectomy and neoadjuvant chemotherapy was done. She received paclitaxel and trastuzumab because she is HER2 receptor positive. So trastuzumab dose was 4 milligrams per kg IV over 90 minutes, then 2 mg per kg over 30 minutes every weekly. So next slide, please. So she was doing fine, but after a year, she started developing dyspnea on exertion, which was initially functional class 2, then slowly progressed over the next 2 years. At that point, trastuzumab was stopped actually, but she progressed over the next 2 years to severe chemotherapy-induced cardiomyopathy. She was again managed medically, and she was doing okay for 6 years, but despite optimal medical management, her LVEF deteriorated, and finally she landed up in refractory heart failure. EF was around only 25%. She was also evaluated, PET CT, everything was done, and she was advised cardiac transplant. After post-transplant 3 years, she is still doing well. And coming to the last case also, she's also a 51-year-old female, right-sided breast cancer, stage 3, underwent radical mastectomy, neoadjuvant chemotherapy with cyclophosphamide, epirubicin, and 5-fluorouracil. And she's also HER2 new receptor positive and was given 14 cycles of paclitaxel and radiotherapy for the metastatic breast cancer. Baseline cardiac evaluation was normal in her. She was started on trastuzumab once the cardiac parameters were confirmed to be normal, and it was next slide, please. So after 3 months, she started becoming symptomatic, could tolerate only up to 12 cycles of trastuzumab. Then it was stopped, but her dyspnea, palpitations, symptoms got worsened, and echo was showing dilated LV, global hypokinesia, thinned LV, and with the EF of only 20%. So she was kept on medical management, but despite that, she progressed, deteriorating. So she was also evaluated with a PET CT and underwent cardiac transplant. But post-transplant, after 1 year, she developed liver metastasis, deteriorated, and succumbed. In this particular case, LVAD was not considered because of financial constraints. So this is basically the gist of the 4 cases, and now our cardiologist and expert will overview in the following things: just the definition, epidemiology of chemotherapy-induced cardiomyopathy, and which patient to consider for transplant, and how do we go about the process, preoperative workup that is necessary, and other mechanical circulatory devices support RVAD, LVAD, and differences with the transplant related to non-ischemic or ischemic cardiomyopathy, other subsets of cardiomyopathy, and immunosuppressions used in this, role of the endomyocardial biopsy on follow-ups, any complications that are associated on follow-up, and overall outcomes, and how the patient should be followed up. And next slide, the oncologist will overview about the drugs which we use and what cumulative dose and survivors of cardiomyopathy, when to refer for transplant, what are the current guidelines, and preoperative challenges, how to rule out malignancy, that patient is in remission, and there is a how to predict his survival. Very important point is the role of the PET CT, both in looking out for the remission as well as to follow up the patient later also, and immunosuppression related malignancies, and how to detect cancer relapse and overall outcomes of the patient.
So, thank you, Dr. Uday. So, may I now request Dr. Debashish Das actually to give the expert cardiology overview. Dr. Debashish?
Yeah, Dr. Debashish, you have to unmute yourself.
Yeah.
Thank you, sir, and thank you everybody for the invitation. I'm a cardiac surgeon, so there is a bit of a disclaimer here. And what I'll do is I'll give a cardiac surgery cardiology perspective on this rare subset for a transplant, because in the if you take the overall transplant perspective, chemotherapy induced cardiomyopathy leading to cardiac transplant will be a minority of the entire number of people who would undergo this procedure. So
Dr. Uday, I wanted to ask you one question. Are you continuing, Dr. Debashish?
yeah, you can ask the question. Yeah, that's not.
No, I was just wondering if this came about because we didn't give so much importance to ejection fraction before we started the chemotherapeutic agents, or we didn't do it cyclically or in a longitudinal manner. Because I've been following a lot of these patients, and a cardiac transplant seems a little rare to me, but obviously you must have seen.
So I think what happens is it is both. So these are the points which I was supposed to cover, which I'll try and do
please
to answer Dr. Asiwal's question. Basically, I think there will be. It is some of it is dose related, which I think in the current realm of oncology being so monitored and sophisticated, will be rare to have a dose related sort of cardiomyopathy leading to heart failure leading to transplant. However, there are certain patients in which it is not dose related. It could be just idiosyncratic, and those would be the populations in which we can actually monitor them and pick it up before they reach that stage of irreversible cardiac failure. So by definition, chemotherapy induced cardiac failure would be leading to sort of significant cardiomyopathy, would be a development of heart failure and reduction in ejection fraction, which is sort of greater than 15% from the patient's own baseline, or a 10% reduction if the ejection fraction is less than 50% to start with. And to my surprise, I think it is not so uncommon. So the prevalence in patients who are receiving chemotherapy, it is almost 3 to 8%. You all would probably know better that anthracyclines is the commonest, and mostly it's cumulative dose related, rarely idiosyncratic. The decision to do a transplant is more or less similar what we would do for a normal heart failure patient. So one, the patient has to be symptomatic. 40 is probably too conservative. We would even go up to say 55 years of age, because more than 55 years of age, a cardiac transplant recipient would probably, we would do a risk benefit analysis on a particular case and then only take it. Uh, uh, Usually sort of just to choose a preferably male, they do better prognostically with no end organ dysfunction, because they have been receiving a lot of chemotherapeutic agents. So renal functions, liver functions, other parameters have to be well preserved. Obviously he has to on the ejection fraction has to be less than 30%, and he has been given a thorough chance for medical management with all the beta blockers, ACE inhibitors, ARBs, and even ARNI. So, and in all other sort of, if there is anything to do with the CRTD or any cardiac resynchronization therapy which has been done to make the ejection fraction better. So it's a usual workup. And the preoperative workup of these patients would actually include detailed sort of blood work, including the liver function test, the coagulation parameters, the thyroid profile, ultrasound whole abdomen, and if the patient is in NYHA class 3 or 2 and sort of is varying between the two classes where it is an ambulatory patient, I think that is where the role of CPET comes, a cardiopulmonary exercise testing, where you objectively evaluate the VO2 max, as the oxygen capacity, to see as to whether this patient actually fits into the criteria of putting him for such an extensive procedure. So the CPET is, if it is less than 14, then obviously the patient is a candidate. If it is less than 12, there is no doubt about it. The patient undergoes a right heart cath to evaluate the pulmonary hypertension part of it, as well as the condition of PVR, to know as to how good the lungs and the PVR are, so that to have an idea about how to manage them post-op. Then we have a detailed heart team discussion, and then the patient undergoes a heart transplant. Now, in certain patients, because organ comes at a premium, so we are living in a part of the world where organ donation is still in infancy, so and assist devices are very costly. So although in the Western blood these devices would be used as a bridge to transplant, as a destination therapy, many times the dysfunction is biventricular. So the right ventricular function requires equal attention, if not more. And sometimes you would actually, if you need to bridge it, they might require a BiVAD rather than just an isolated LVAD or a RVAD. The cost and the maintenance of a patient on a ventricular assist device itself is quite intensive. So how relevant it is to us is actually has to be individualized to the patient. Now, what are the differences with transplant vis-a-vis other patients who undergo transplant? I think, as Dr. Uday said, ensuring that the primary malignancy is in proper remission is paramount. So, a PET scan which clears the patient that the ongoing malignancy has been taken care of is the first criteria. Other organs, mainly the kidney, lungs, liver, should be as normal as possible to have a smooth post-op course. Uh, whichever is the particular malignancy, what are the theoretical chances of recurrence, we should keep that in mind. And also the particular malignancy, whether it has any effect of the immunosuppressive regimen which would be given to this patient, which can have a effect on the malignancy behavior. So these are the important differences. In addition to this, technically as surgeons, if a patient has had a radiation therapy, or some patients actually to chemotherapeutic agents also have severe adhesions inside the pericardium as a result of pericarditis, which makes surgery a little bit more challenging when we enter the chest to explant the native organ. So radiation and chemotherapy induced pericarditis and adhesions is one peculiar feature of these patients. In addition to this, the immunosuppression that we follow in our center, although we haven't done a chemotherapy induced cardiomyopathy so far here in our center, is a standard induction followed by maintenance. So we give a combination of methylprednisolone and basiliximab during the surgery, and then from day 2 onwards, it's a combination of mycophenolate and methylprednisolone along with tacrolimus. Tacrolimus trough levels are then assessed cyclically, and usually the mycophenolate and tacrolimus will continue. We would taper the IV steroid to an oral steroid and continue to taper it throughout the follow-up period. In addition to that, Van cyclovir for CMV infection and other things are added as a adjunct. So this is the standard. This is the most common immunosuppressive protocol that is followed in most of the centers, and that's what we do. So it's a combination of multiple agents with monitoring of renal parameters, mainly because of tacrolimus, as well as other factors, to see that the trough levels are adequate to provide a good immunosuppression for prevention of rejection. Now, the main thing in any transplant is the fear of organ rejection. So, in this current era, hyperacute rejection happening on table is probably unknown because of the good immunosuppressive regimen that we have. So, mostly it is either acute or even late. So, the role of endomyocardial biopsy, this is the gold standard for rejection assessment. Usually, historically, the frequency of myocardial biopsy was very high. They would even do weekly for the first 1 month and then sort of every month. But nowadays, most of the centers have reduced the frequency of endomyocardial biopsy. What we follow is 1 month, 3 months, 6 months, and then a year later, and then yearly, or whenever there is, if a patient presents with a new onset ventricular dysfunction of unknown cause, and we would actually suspect something, we would actually prepone the scheduled biopsy and do it beforehand.
Thank you.
And then these.
I'm sorry.
Sorry, yeah.
I thought you were winding up.
So, and then the usual complications are after a transplant or low cardiac output, need for ECMO, RV dysfunction, because the right ventricular is the main thing which has to be taken care of after a transplant, whether the patient needs an INO for pulmonary artery hypertension or a support in terms of extracorporeal support for RV dysfunction. Sometimes they would require a renal dysfunction, and obviously as we are using significant immunosuppression agents, infection is of paramount importance, and prevention takes the main seat. As far as the cardiac and overall outcomes, this is no different from any other allograft recipient. So, a patient who undergoes heart transplant for a dilated cardiomyopathy of idiopathic cause and a chemotherapy, more or less their survival are similar. So only a tiny bit of heart transplants are done in outside Europe and North America, but still the number is increasing. This is the International Society's registry showing the total number of transplants. And so the average survival in a post chemotherapy induced cardiomyopathy is more or less similar to what a normal cardiomyopathy patient undergoing transplant would be. And this is the usual follow-up schedule that we follow. So usual clinic usually would be weekly, then bi-weekly, then 3 months, then 3 to 4 months, and then we would schedule is 6 monthly. Patient would have an ECG, a Holter monitor every 6 months, echocardiogram with each clinical visit. That's a very sensitive marker of any new onset dysfunction, should be treated like a rejection. Endomyocardial biopsy.
Debashish Das, my apologies, time is up. Can you go to your last slide and conclude,
Yeah,
please?
so more or less this is the last slide. So this is how we would follow up. So although it's a rare entity, post cardiomyopathy patient undergo post chemotherapy induced patient having cardiomyopathy undergoing a transplant, as the number of patients undergoing this therapy increase, I think it will be a more common thing that we'd see, and this is a unique subset of patient which needs to be dealt specially.
Thank you, Dr. Debashish. May I now request Dr. T. Raja to speak on the oncology overview. So, Dr. Raja, you have 5 minutes. Please go ahead.
Thank you, Dr. Vivek. Thank you, the organizers, for this wonderful opportunity. It's a very different task. Most of the time, we are very happy to leave the subject to our cardiologists, but we understand that there is an increased, there are competing risks between the cancer patients and the cardiovascular disease manifestation. As the cancer survivors increase, the cardiovascular disease are going to increase, and as the age increase, actually there is a competition between both the diseases. And we know that the spectrum of cardiotoxicity with what we do in oncology is not just a single entity, cardiomyocyte damage, thromboembolism, hypertension, so on and so forth. There's a spectrum of cardiotoxicity. What is more important is that different drugs, it's not only anthracyclines that causes cardiomyopathy and cardiofailure, but there are other drugs that we need to be aware of. Fluoropyrimidines, everybody talked about the myocardial ischemia, and there is very little way to predict what's going to happen with them. You can't pick and choose a patient. And we have very innocuous looking drugs like VEGF inhibitors causing hypertension and doing something. Even androgen deprivation can lead to cardiovascular event. There is a whole range of drugs that can do a whole range of things as far as cardiotoxicity goes. But it is relevant to understand some of the key mechanism of some of the important drugs. The anthracyclines, oxidative stress mechanism, and mitochondrial iron accumulation, and the fluoropyrimidines, vasoconstriction, and impaired ROS handling. And similarly, the anti-HER2, which is something very, very commonly spoken about in the cardiac spectrum, is antagonism of HER2 pathway, so on and so forth. But broadly, we can understand the cardiotoxicity as either on-target toxicity of all these drugs, cytotoxic drugs, causing mitochondrial defects, or causing the topoisomerase 2 enzyme defects, or some of the drugs can cause off-target toxicity also. it is relevant to point out that most of the toxicities, as we know, of fluoropyrimidines and trastuzumab are actually reversible. With diligent cardiac management, these are reversible, but some are permanent, like the anthracycline, which are cumulative, dose dependent. Similarly, radiation-induced coronary events are also dose dependent. I've talked about the off-target cardiotoxicities, and some of the simpler looking tablets can also be difficult. For example, a very new drug called ibrutinib, which is a Bruton kinase inhibitor, can also cause arrhythmia, so on and so forth. So from the oncologist's point of view, we need to be aware of which are the reversible. Most of them are reversible, but some of them are dose dependent and therefore are not reversible. And mostly the anthracyclines that we talk about. And we need to look at what is going to be the prognosis of the patient when we refer for transplant. And oftentimes we are called for preoperative assessment for coronary events. Many times patients get admitted for coronary ischemia, and then they're going to do a procedure and they call us to clear from cardiology point of view. We very rarely encounter a referral from a cardiac transplant team so far. But I think the principles are the same, to look at whether the patient has an active malignancy and what is the prognosis for the malignancy. Role of PET-CT cannot be overemphasized in looking at the presence or absence of a malignancy, and you can give a relative prediction of what will happen to the malignancy. And we need to look at the overall outcome and survival of the patient before you recommend them for a transplant. I'm not even going to hazard on what will be the role of immunosuppression, so on and so forth. I know that there is hard discussion on everolimus as one of the post-transplant agent, which can have some of the anti-cancer property and so on and so forth. And there is controversy whether early or late everolimus. So this is purely post-transplant surgeon's domain. So what I would emphasize is that continuous assessment and continuous cooperation with your cardiologist and very, very aggressive management of your cardiology patients can mostly avert the situation like a transplant. Sometimes you may have to end up referring a patient for transplant in the right patient, and look at the prognosis of the disease and the prognosis post-transplant. That will give you the answer, what to do with this patient. So heart is at the prime. And thank you for listening to us.
Thank you, Dr. Raja. This was a brilliant exposition. So I think we've had a very interesting session on cardiac transplant from the chemo-induced cardiomyopathy and from you. So I would like to know from Dr. Vivek and Dr. Parikh, please, we are running out of time. So would you guys like to thank everyone, or do we take questions? As you said.
Yeah, I think, sir, we are already run out of time, so we would like to conclude.
Well, thank you very much for inviting me. I really appreciate that. And I had a lot to learn. Thank you.
Thank you so much, sir. I now request the Asian Cardio-Oncology Society Honorary Secretary, Dr. Vivek Agarwal, to please give the vote of thanks. Over to you, sir.
Yeah, I think we have already run out of time, but we had a wonderful session today with Professor Susan Dent coming in and giving a wonderful lecture on cardiopreventive mechanisms and how we have to go about it. I think Dr. Hisham did a wonderful job on moderating the session on how do we go about cardiac imaging as well as biomarkers in monitoring our patients. I thank all the faculties who participated in this meeting, and I thank all the audience for active participation. Again, request everybody to kindly take in the membership of Asian Cardio-Oncology Society and help us in continuing this initiative. Request you again to join next Thursday for our 4th series. Thank you and good evening.